Thank you everyone for joining us for the webinar on the theme Optimizing Treatment in Lung Cancer. Without wasting any further time, it gives me great pleasure to introduce our program director, Dr. T. Raja, who is a medical oncologist from Chennai. And I request sir to please give the introduction and the context setting. Over to you, sir.
Thanks, Kashish, for this introduction. Thanks, AstraZeneca, for putting all of us together. And it's a great meeting. We really look forward to listening to some very, very good lectures. And the trouble is, we all, are so familiar with EGFR therapeutics, and we feel so familiar with Osimertinib, but sometimes there could be many blind spots. And I think this meeting is trying to explore, what those blind spots could be and how we can take it into the real world and so on and so forth. We're going to have some excellent lectures. The first one is from my very dear friend, Dr. Limaye. She's going to speak on molecular biomarker testing in lung cancer. And then, we really look forward to listening to that lecture. And then I'm just going to briefly touch upon real-world experience with Osimertinib. And then we are going to have our international speaker, Professor Herbert Loong. We're going to hear the lecture on experience sharing in the management of early EGFR mutated non-small cell lung cancer. And we're really excited to, and look forward to hearing that lecture. And thereafter, we have excellent Indian faculty and moderated by Dr. Senthil Rajappa. And they will be deliberating on all the aspects of the management of EGFR mutated non-small cell lung cancer. So we look forward to a real academic fair here. And without wasting any more time, I invite and request Dr. Sewanti Limaye to go ahead with the lecture on molecular biomarker testing in lung cancer. Dr. Sewanti.
Good evening, sir. And very good evening to Dr. Loong as well, and to the AstraZeneca team and all the friends and colleagues that are here this evening, and also all the listeners who are seeing our program. So we are going to begin with the molecular biomarker testing in lung cancer, and I'll take you through this with a rapid fire, mainly because most of us are already practicing what I'm going to show. There are certain nuances that I'm just going to touch upon, and interesting new facts around the biomarkers. But overly, most of this is already being practiced by most of us, and so this is essentially a revision. So a few words about lung cancer incidence and mortality. And if you just look at this slide, the incidence in lung cancer and mortality on the right-hand side, the incidence and mortality rates are quite significant. As you could see, we are able to save a lot of our breast cancer patients. We need to make improvements in the lung cancer mortality rates and the number of patients we are able to save once diagnosed with lung cancer. And as we know, large percentage of lung cancers are diagnosed in advanced stages. And so the current lecture is very relevant, and the entire symposium based on targeted therapies in lung cancer, most relevant as well. So lung cancers in India, fourth most common overall incidence among cancers. And when you look at lung cancer in men and women, and the number of deaths, and including both sexes, these are Indian numbers, and they are very stark. It is second most common cancers in males in India, and sixth most common cancer in females. and most common cause of death in men with cancers in India. Male-female ratio, again, males are higher in number because of the smoking exposure, and that's one high-risk factor that we need to shun. Smokers versus non-smokers, 20:1. That's the Indian rate, and I'm sure very, very similar to the international rates as well. So when we look at evolution of lung cancer diagnostics, we have the histopathology-based diagnostics, and now we have the molecular diagnostics. I think lung cancer is the leader in precision oncology, and you see various molecular alterations, pathway-driven disease, where our job as medical oncologists is to find the pathway, be the detective, find the pathway, and there is a whole host of pathways that we are enriched with when we are looking at adenocarcinomas, and more so in Asians, because Asians, especially non-smoker Asians, we have to be true detectives, and we have to go after finding the pathways before we can consider non-pathway driven disease and treat these patients with chemotherapy or chemotherapy plus immunotherapy. We truly need to go after figuring out the driver mutation in these patients. And as you see, in squamous cell also, there are pathways that are being discerned. However, they're not ready for prime time utilization yet. It's majorly the adenocarcinomas wherein we find various different pathways, and most of our work now is focused on pathway-driven disease versus non-pathway-driven disease. In lung cancer, I think that is of paramount importance for us to figure out whether we are dealing with a pathway-driven disease or a non-pathway-driven disease, especially in Asians, considering the high incidence of pathway-driven non-small cell lung cancer, specifically lung adenocarcinomas, where the onus is on the medical oncologist to play the detective and figure out the pathway. So this is a timeline chart, and I find this very intriguing. It was recently tweeted, and from very nice manuscript, wherein you see the timeline of emergence of different pathways and how we are enriched with pathways today. This is all comers, all malignancies, but a lot of these pathways are actually coming from lung cancer. So when we look at the adenocarcinomas, what are most of us, or what is India doing right now? Most of India is doing EGFR, Ulc, ROS, and stretching it to Pdl1. A lot of us are also doing BRAF, RET, MET upfront, but largely India is still doing EGFR, Ulc, and ROS testing. And that is in first line setting. We're also looking at Pdl1. And if we go on to the second line setting, we are looking at T790M largely. However, the field is really progressing, and those of us who are practicing more precise treatment are doing multi-gene analysis beyond single gene testing with next generation sequencing and comprehensive genomic analysis. So different methodologies for testing, and I will quickly touch upon some of the tests for specific biomarkers and the evolution. And so we know when we look at more than a decade and a half ago, when lung cancer used to be a death sentence, and I would ask my peers who wanted to become thoracic oncologists, why are you going into this branch? This is really a branch associated with death and dying. Little did I know, and very soon was I to realize that the paradigm had shifted. There was a revolution in treatment of lung cancer, and we saw how histopathology then evolved into single gene analysis for EGFR testing in early or late 2000s, and then into single gene multiplex testing or next generation sequencing, where comprehensive genomic analysis was happening in tissue and then in blood. And when we look at EGFR analysis or EGFR mutation testing, we are initially we were largely talking about exon 19 and 21, which are the most frequent EGFR TKI sensitizing mutations. But we all know now that there are many more EGFR alterations in between 19 and 21. And it is, again, our job to really understand the others and understand the application of therapy of the TKIs and the other targeted therapies to the different kinds of EGFR that we come across in our testing, and not just in our testing, in our treatment. We also come across complex presentations, and we have to be aware of what the presentation is and how to treat those presentations. In terms of testing, we have evolved from routine single gene analysis, as I said, to multi-gene analysis. And from the tissue collection perspective, we have also evolved from tissue where we took FFPE. We can do the testing on fresh frozen samples. We can also do the testing on cytologies, cell blocks, blood-based analysis. And the responsibility on tissue collection still remains because of the requirement of appropriate tissue for a lot of these broad panel sequencings that we do in order to detect the alteration. And when we look at the tissue collection, I think it's a new age era of novel biomarker related tissue analysis. And that's where more precise tissue collection is, again, a requirement and imperative to current analysis, biomarker analysis, molecular testing, so that we can find markers appropriately and treat the patient, find your markers appropriate and treat the patients accordingly. So we have to have very sensitive testing methods that are able to detect mutations in specimens with less than 10% of cancer cells. And EGFR mutations could be in a very low frequency, and one has to figure out what's to be done with even the low frequency and whether to target those mutations at a low frequency. And in terms of the tests, we have small targeted panels. And from there, we have comprehensive genomic analysis, and broader than that, whole exome sequencing and whole genome sequencing. And we have been hearing all the buzz around tissue analysis and molecular profiling and how to improve the profiles across our country as well as across the world. And I feel that this field is really evolving and catching speed. Then it brings me to early stage EGFR mutation testing. And at our center, we had looked at the early stage EGFR alterations. And these numbers actually match very much what we are seeing in this particular publication, wherein if you look at stage 3 where the application is, or stage 2 where the application is, and the rates are much higher than what you see in the US or Europe, as would be consistent with Asians having higher EGFR percentage or alteration. The NCCN guidelines also recommend testing EGFR in early stage non-small cell lung cancer. And I think now we are all aware that this has become a standard of care guideline where you are testing specifically EGFR in early stage lung cancers to then determine whether the patients that we see are candidates for maintenance therapy with EGFR directed treatment. Moving on to Ulc rearrangement, we have Ulc rearrangement that occurs in 3 to 5% of non-small cell lung cancer in India. There are different testing methods. Largely, Ulc by IHC is utilized by most of us. It is less expensive, readily available, and most widely adopted in India. FISH analysis is also considered a gold standard. And we have the Ulc by RT-PCR, we have Ulc by NGS analysis, we have RNA-based assays where we have to be aware that the FFP material may fall short, and we may need to collect the tissue in a different kind of solution called RNA later, so that we can do the RNA-based analysis with more proximity. Then there are variants in Ulc that are being described now, and we have to get up to speed with what do these variants mean and which molecule will be able to help with which variant of Ulc rearrangement that the patient is presenting with. And why is that important? Because now there are different drugs that are coming in, first generation, second generation, third generation Ulc inhibitors, where we absolutely will, not yet, but will have to know which variants are being covered well and which are not, so that we can appropriately utilize that specific TKI. And then the ROS1 rearrangements in NSCLC, and you can see the number of rearrangements that are there. And again, small percentage in Indian lung cancer, around 2% of ROS rearrangements found in lung cancer. And again, very important to understand the methods of testing. So we have the FISH testing for ROS1, which is considered to be the gold standard. And we have other methods of testing, including NGS and RT-PCR testing, and the IHCs as well. So we just need to know the algorithm with which we have to approach each one of these alterations. These are three most standard alterations that get looked at. But beyond this, there's a fourth one which has come in. And I would say in between somewhere there is BRAF, RET, MET that has also found its importance with most of us. And I'm scooting over to what gets done in India largely at large, and that is the Pdl1. So EGFR, Ulc, ROS, if the patient is found to be negative, you have the Pdl1 testing to be done. And we know that there are multiple different kits that were developed as companion diagnostics along with the drugs. So you have the DACO 2233 with pembrolizumab, you have the DACO 288 with nivolumab, and Ventana 263, SP263 with durvalumab, Ventana SP142 with atezolizumab. And again, we have various cutoffs for various disease conditions. Extremely important to know these cutoffs. I think as we go on with multiple different drugs and different utilizations, I think we'll have to all have a master slide to go to look at, so that we can then appropriately offer the medicines, offer the immunotherapy drugs to the patient. It hasn't gotten that bad yet. And for now, I think most of us remember the numbers, but I think it's going to get tougher and tougher as the biomarker nuances evolve. And so you have Pdl1 testing laid out here with different kits that you can see what does a positive SP263 and SP142 look like, and what are the differentiators. And so then moving on to the other alterations that we routinely look for. And we in India are still not specifically, those of us who are doing single gene analysis, or we happen to do single gene analysis, we're still not looking specifically for KRAS, because we don't have access to KRAS inhibitors in particular. Having said that, where we utilize comprehensive genomic analysis, we have, or the lung panels, our secondary panels are also containing KRAS as an alteration. And we know that one of the new kids on the block, KRAS G12C inhibitor, sotorasib, is very much there. And we all, in India, we are actually waiting for the arrival of this drug and additional clinical trials to help us target KRAS. So a lot of the tests are now moving on to multi-gene testing, next generation sequencing, and also comprehensive genomic analysis, just to be able to give you the complex the ability to analyze the complicated presentation of different genomic alterations that can be seen in a patient. And a lot of work is happening in prognostication and predictability of treatment application in non-small cell lung cancer. I'll quickly run through a few slides where immune biomarkers are also becoming critical other than PD-L1. It's the tumor infiltrating lymphocytes, where you can see a lot of work is happening where tumor infiltrating lymphocytes could reflect on whether a patient is going to respond to immunotherapy or not. PD-L1 has been there for a very long time, and we have clinical trials, Keynote 024, Keynote 189, 407, 042, a whole lot of studies based on the PD-L1 status. And then we have the tumor mutation burden, wherein we saw the seminal paper by Rizvi et al., where high tumor mutation burden versus low tumor mutation burden, there was a higher predilection to response with anti-PD-1 therapy with high TMB. And there are various methods of testing the TMB. Why is it important? Because if a patient with lung cancer had no other biomarkers but had a high tumor mutation burden, would you then think of treating with immunotherapy? And so these are questions that are arising. These are realities in our clinics as we do the comprehensive genomic analysis, which spits out the tumor mutation burden, and go figure, you have all these answers which you need to then apply. So you have various different methods. I'm not going to get into the details in interest of time, but you have application to several trials where high TMB got looked at as a predictor to response from immunotherapy. And Checkmate 227 was one such trial where we saw improved progression-free survival with high TMB patients in presence of combination immunotherapy. And then you have blood-based TMB that is also evolving. It's not ready for routine prime time utilization, but a lot of us are really looking at blood TMB for application to precision treatments. And then you have MSI, you have BRCA, you have many subtle biomarkers. And this one last slide, wherein the entire immune biomarker arena is exploding with other immune biomarkers for treatment application. Most of these are in clinical trials right now, whether it is about single agent immunotherapy that is evolving, or whether it is doublets that are being tested, wherein you combine one already known immune checkpoint inhibitor with one of the developing checkpoint inhibitors like OX40, GITR, LAG3, and many more. The idea is to combine treatments wherein you activate the T cell from its base and you apply the PD-1 in assistance to the activator to enhance the immune response. And one such biomarker analysis testing, I just came across an immunogram wherein a chart of the different kinds of immune biomarkers were placed, and application to immunotherapy in clinical trial setting was enhanced because of the chart and the immunogram that was developed out of the testing for that patient. Most importantly, I think it is the turnaround time for lung biomarkers. I itch every time I send the test because it's so important for us to get the test results in time. It's critical for us to have these results because many of our patients could then be exempt from chemotherapy. If they are Asian, non-smokers, especially a female, there's very high chance for this patient to come out with a driver mutation that could be targeted. And in such patients, to then subject them to chemotherapy really appears unfair. We do that all the time because we don't have these tests coming back quickly. So ideally, we should be having the tests come back within 2 weeks of time frame. I actually push for less than a week, and ideal would actually be 3 days. Even better if you could get these results in your clinic while you're seeing the patients within a few hours. With that, I think I leave you with two messages from the biomarker analysis. One, the biomarkers are exploding. There are new and new biomarkers coming through. There are nuances coming through where combinations are also evolving, especially when you get into the era of resistance pathway understanding and application of multi-target, multi-pathway therapy for to overcome the resistance. One, and two, immune biomarkers are also exploding to enhance the application of combination therapy, whether it be immunotherapy and targeted therapy, like we see in the situation of BRAF positive lung cancers, or whether it be combination of targeted therapy. So that is the most important thing. If we don't have the test results back, you will be treating the patients in a generic way, and gone are those days. With that, I hand over the podium back to Raja sir for the next section of the symposium. Thank you very much.
Thank you, Dr. Sewanti. It was a very excellent lecture, very exhaustively covered, I would say, right from the basics to what is exploding around us. I think that was, I would say, it was an intimidating introduction to what's going to come very soon. So mind-boggling. We need to have some sort of device, PDA device, to keep on looking at all. That's what is going to happen. Excellent lecture. Thank you so much. I'll quickly move on to present the real-world experience on. Can I allow?
Sure, sir. You can share your slides, sir.
Thank you.
And also to let you know, this session is sponsored by AstraZeneca. Over to you, sir.
Thank you for mentioning that. So that's the disclaimer. And we are just going to present, I'm just going to quickly run through the real world evidence of Osimertinib as a standard of care. I think everyone is very, very aware of the first line therapy with Osimertinib. And that is well established by the phase 3 randomized controlled trial, FLARA trial. And we know that Osimertinib can deliver a median progression-free survival of 18.9 months versus 10.2 comparator arm, and the overall survival, median overall survival, has also matured at 38.6 months with Osimertinib. So that's a very, very impressive first-line data, and which is a practice changing data, I would say, in the large. And this was presented by Dr. Suresh Ramalingam in ESMO 2019. The final overall survival was presented in ESMO 2019. And I mean, the comparator arm was Gefitinib and Erlotinib. And the primary endpoint was PFS, and the secondary endpoint was overall survival. And one other special thing is that there is crossover allowed whenever they are on the Gefitinib, Erlotinib, and you can demonstrate a T790 mutation. These are the very essential about the study design. Baseline characteristics, there were 270 patients plus on both the arms, and they were well stratified, I would say. And EGFR mutation exon 19 deletion or L858R is the must, and it is around 60-40 ratio. And then comes the primary analysis, which is the progression-free survival, and the PFS is 18.9 months, as mentioned. And all the subgroup, right from the sex to the age and to the smoking history to CNS metastasis, controlled CNS metastasis, so on and so forth, and the type of deletions, exon 19 deletion or L858R, all of them favors Osimertinib, and the hazard ratios are very close. It's somewhere spread between 0.3 to 0.4 and 5. And the final analysis on overall survival, there is an overall survival superiority of 38.6 months versus 31 months, and with a hazard ratio of 0.79. And you can see that at 36 months, landmark analysis, 54% of the patients are still ongoing. So significant PFS, OS, median overall survival difference, 6.8 months. So this is really kind of a practice-changing data. Therefore, the NCCN would now call it as preferred, either if the patient is detected to have this EGFR activating mutations, either discovered prior to any of your systemic therapy, or even if the first-line therapy is ongoing, you are at liberty to cancel or discontinue and switch over. But does that really, also meet out in the real world? All these evidences are applicable in the real world, where the patients would be not exactly the clinical trial profile. There will be a wide range of profiles. So that's what is our interest. I just want to present 3 data sets. One is the flower study, and the second study is known as OSIFACT, and the third data is known as Myconas. All are real world evidence. And flower study is basically an Italian study, first line Osimertinib. And why would we need that? Because they would argue that only less than 10% of the patients would really get into a clinical trial criteria, and then again there will be different subset of patients, and you can have some unique insights. That's what is the basic argument why this study was embarked, and the number of cases were 126. And you would see that brain metastasis is seen around 38, 30% of them had brain metastasis, and that's very important. And the study endpoints, slightly interesting. They used an endpoint known as TTD, that is time to treatment discontinuation. That is osimertinib discontinuation for any reason. So which is kind of a real life pragmatic endpoint, and that is going to reflect some of the common practices beyond your RECIST assessment. You're going to talk about oligoprogression, and sometimes you want to persist when there is a good tolerance and you think the progression is very minimal, and so on and so forth. So that's a real life discontinuation rate. And the other thing is diagnostic pathways were also looked at. That is time frame from biopsy to where you really start, and whether the patient underwent some loco-regional therapy, and the type and frequency of the biopsy. All these were looked at, and fortunately most of the outcomes were very similar to the published FLORA data, and particularly the PFS, TTD, and the OS were also noted to be in the elderly patient and patients with comorbidities, and slightly less common EGFR mutations were also looked into this, and these were not in the FLORA inclusions, and there also most of the data turned out to be close to the FLORA data. The primary assessment is effectiveness, and time to treatment discontinuation is 25 months. An interesting thing is that when there are no symptoms, the time to treatment discontinuation median is not reached. Similarly, if there is less than 3 MET sites, then the time to discontinuation is still not reached. So that's very interesting observation. And see, the TTD was longer, 25 months or so, and better in patients with less than 3 sites, and when there were no symptoms or very few symptoms. So that is something that we can keep in mind when we make decisions on patients in front of us. And the other thing is that whenever there were symptoms and whenever there were more than 3 metastatic sites, the outcomes seem to be poorer. And this is the various subgroups that are displayed here out of this trial. And you can see that symptoms at diagnosis, and the next one is the number of sites, less than 3 or more than 3, brain metastasis at diagnosis. All of them show an unfavorable outcome whenever these factors are present. And so now, in a quick summary, these patients were shown to have a PR of about 73%, stable disease of 23%. And the other primary assessment was effectiveness. Once again, the effectiveness was much better in patients when there were no brain mets or when there were no symptoms. That's something. here. And so basically, this study in real world experience would state that longer PFS when there is absence of brain mets. This is kind of intuitively known, but then it is now out of a real world data, and prolonged PFS when there are no symptoms. And this is what we learned from the real world data. And again, among the patients who have experienced progressive disease, 47% of them underwent a rebiopsy. That is something similar to what happens in the real life setting in affordable settings. And molecular analysis was performed in patients when they were progressing. 61% of them underwent a second molecular analysis. With regard to safety, 87% of them showed some form of adverse event, and in particular venous thromboembolism was of interest, 9.5%. And the venous thromboembolism was the most common among the some of the special adverse event. And there was no difference in the venous thromboembolism depending on the age, PS, comorbidity, or tumor load. That is something that is very unique. Number of metastatic site, ECOG, or age, there was no difference in the venous thromboembolism. That's something that is out of that particular trial. The other data set is the OSIFACT. This is the East Asian OSIFACT. This is basically a Japanese data set, and this investigates the efficacy in this particular patient background. And the number of patients are 500 plus. And here the primary endpoint is PFS. Secondary endpoints are OS and TTF, so on and so forth. The primary endpoint median PFS is 20.5 months in the Japanese data set. And the some interesting observations from the Japanese set is that male gender and when they were associated with a better PFS. And if you have malignant effusions and liver mets and advanced unresectable disease, they have a poorer PFS. So this is already known. But one other interesting observation was with respect to Pdl1 expression in patients with EGFR mutations and who are on Osimertinib with Pdl1 expression TPS of less than 1%, the median PFS is not reached. So that kind of is aligned with what we know, that if the Pdl1 is, that's not a candidate for immunotherapy in some way. And if the TPS is less than 14%, it is 14.1 months. The TPS more than 50%, you see a strange observation. The PFS is 11.1 months. This kind of answers the question where we always ask, what is the interaction between Pdl1, EGFR, and some answers are there. And reasons for discontinuation. Here you see that the biggest reason is disease progression, 44%, I'm sorry. And pneumonitis in 25%. That's very important. Do we see that number of pneumonitis on Osimertinib that we discontinue? I'm not very sure, but this is the Japanese data, and other adverse events are 16%. And safety is otherwise very similar to what we know, except the pneumonitis, which is something standing out here. And the discontinuation rate, especially pneumonitis, requires further investigation. That's their conclusion. The third data set is, this is basically US data set. It's actually a global study, but this is the US population in particular. The US sub-analysis is presented here. I think it is, again, I'm not sure about the number, at least let me look at that. Yeah, 500 patients once again, very, very robust numbers. Again, this one looked at Caucasian white and African Americans, Asian. So a good mix of the real statistics in US is represented here. And the clinical characteristics are all well known. But the bottom line is that the treatment efficacy was very similar to the FLARA data. And again, if you look at what happened on progression, how did the sequencing happen in the United States setting? how many of them received the second line. That's about 103 of them received second line out of the 500. So roughly, it's about 20-25% of them went on to receive second line. So that's what is that. And most of them are kind of, Pdl1 had an influence in their second line choice. That's what, so we could, and 300 of them were lost to follow. That is around 60 to 70%. In United States, we are lost to follow up. And again, 20-25% of them died on the first line treatment. And this is the time to final discontinuation, whatever be the reason. And one interesting thing is that in the multivariate analysis, stage, smoking status, and comorbidity index, all of this were the confounding factors. And so we always think that when patients are in front of us, when they come with all factors that are not exactly included in the clinical trial inclusions or in the clinical trial subgroup analysis, how do we make decisions? I think we need to look into these real world experiences. That's what we are trying to present. And I've just given a quick overview. Hopefully with that, I have conveyed a few points, but then thank you for your patient listening. I then, invite Professor Herbert Loong, and we look forward to listening to the lecture from Dr. Loong and optimizing treatment in lung cancer, particularly in early stage patients. Professor Loong, thank you.
You'll have to unmute your mics.
Yeah, okay. Thank you very much, Dr. Raja, as well as Dr. Limaye for a wonderful introduction and setting the stage for today's talk. It's a pleasure to be able to join my colleagues in India to talk about the role of adjuvant therapies in early stage EGFR positive non-small cell lung cancer. Before I begin, as I mentioned, it's a pleasure to be virtually back in India. I believe I met Dr. Raja about 2 or 3 years ago at another symposium in Chennai, and really look forward to coming back in person sometime soon. And certainly Dr. Limaye, although we have not met each other previously, I think we follow each other on Twitter, and it's also a real pleasure to be able to see you in person, hopefully soon as well.
Thank you. Really, thank you. It's a pleasure.
Yes, thank you very much. Okay, so maybe I'll make a start, and afterwards I believe we have a pretty good faculty sort of panel discussion as well, and I think we could certainly highlight some of the issues that we might be able to find either in my talks or any of the other talks that have been discussed earlier on. So these are my disclosures. So I think Dr. Limaye has already set up a really good stage in terms of panning out the landscape of non-small cell lung cancer over the last 10 to 20 years. But just to recap, I think it was not too long ago, and certainly even when I was a medical student, non-small cell lung cancer was considered as just one disease. You would recall the seminal paper published in the New England Journal of Medicine in 2002 by Professor Joan Schiller and colleagues, which actually compared the 4 chemotherapy regimens in non-small cell lung cancer, essentially platinum-based doublets. And then what we've realized is regardless of whether these patients were treated with cisplatin or carboplatin or paclitaxel or gemcitabine in combination, the overall survival and time to treatment progression were quite similar. And the median overall survival in these treatment-naive patients was only about 7 to 8 months. The median time to progression was only 3.5 months. And certainly this is a far cry from what we are dealing with now in terms of non-small cell lung cancer. And as an example that was discussed earlier on by Dr. Raja, including the FLORA trial, we know that first-line use of Osimertinib in the EGFR positive population, the overall survival in the clinical trial was 38.6 months. And even in the older generation TKIs, the comparator arm, which is gefitinib or erlotinib, the overall survival was 31.8 months. Another population certainly is the ALK positive population. And I always talk to my patients and, as sort of a joke on the side, in saying that, if I'm to have a metastatic non-small cell lung cancer, I would want it to be ALK positive, because those patients tend to survive the longest, and the median overall survival with the Profile 1014 study, again, with a first generation TKI, was 60 months. And certainly you may have heard that recently there are more data coming out from the CROWN study looking at the third generation ALK tyrosine kinase inhibitor lorlatinib with very impressive overall survival data as well. But I think my task really is to talk about the early stage non-small cell lung cancer, and just a quick recap in the fact that even in the situations of early stage non-small cell lung cancer, be it stage 1B, stage 2, or stage 3, unfortunately, in this disease, we're talking about a relatively high chance of recurrence or death. And this is something that we really need to have good treatments for. And certainly in such situations, surgery is being used as a curative intent. In terms of established evidence prior to what we have with the EGFR population, it really is the use of adjuvant cisplatin-based chemotherapy. And this is indicated in patients with resected stage 2 to 3A non-small cell lung cancer, as well as selected patients with stage 1B disease. And just a quick recap in terms of the evidence, or the level of evidence which supports the use of platinum-based doublet chemotherapy. You would recall from the large meta-analyses, which includes the LACE pool analysis of 5 randomized adjuvant cisplatin trials, and that was performed since 1995. Essentially, the 5-year survival benefit is about 5.4%, and overall, the 4% point increase in survival at about 5 years as well in other meta-analyses. Now, I think Dr. Limaye has already shown you this data as well. It really pretty much indicating the fact that in the subset of the EGFR population, we do find EGFR mutations in early stage lung cancers as well. And the distribution, be it early stage or late stage, is somewhat similar. So I think this really has a good impetus for us to consider testing EGFR even in early stage disease, and not just in patients with advanced or metastatic disease. Again, within our population here, maybe more so in Hong Kong, but also in India, we do see a larger proportion of EGFR mutant non-small cell lung cancer than our counterparts in the West. Now, I just want to spend a little time walking through some of the key adjuvant EGFR TKI trials that was instituted in early stage non-small cell lung cancer. And this really helped us set the stage in the use of EGFR TKIs in this group of patients. Now, these are the clinical trials which have investigated the use of first generation EGFR TKIs. And without going into too much detail into the actual results, and I'll talk about each of them a little later, I think just to really impress upon you that these efforts have been done both in a single country as well as globally. But each of these trials have their own special characteristics. For example, the first trial highlighted here, the SELECT trial, essentially is a trial that was conducted in the United States for patients with stage 1 to stage 3A disease. And they used erlotinib as the treatment after the use of adjuvant chemotherapy, but this was actually a non-randomized trial. The RADIANT trial is a much larger trial in terms of the number of patients, but the design of this trial actually included patients which did not necessarily harbor an EGFR mutation, and only a small number of patients within this trial actually had EGFR mutations. And then there was also the EVAN trial, as well as the adjuvant CTON 1104 trial, which again, I'll go into more details a little later on. But just again, to impress upon you that the characteristics of these trials are different. Some of them allowed the use of adjuvant chemotherapy prior to the use of EGFR TKIs. Some also allowed the prior use of radiation therapy, but some did not. Now, going to the trial specifically one by one, I think the SELECT trial, as I've mentioned, is a single-arm phase 2 clinical trial of adjuvant erlotinib in patients with stage 1A to 3A disease. And essentially, patients were put into a single-arm open-label study with the use of erlotinib for 2 years. The primary endpoint was a 2-year overall, 2-year disease-free survival. The results was positive, but again, this was a single arm open label trial, and the statistical setup was to compare against historical control. Now, the Radiant trial, as I mentioned, is a randomized phase 3 placebo-controlled clinical trial of adjuvant erlotinib versus placebo in a 2-to-1 fashion of either erlotinib versus placebo, again, for 2 years. The primary endpoint was disease-free survival. This was a randomized trial. This was a large trial, but again, the wrong biomarker selection was used in this trial because in actual fact, they included patients with EGFR IHC positive or amplification by FISH positive. Having said that, we could probably comment on this negatively only in hindsight, because when this trial first started, we really didn't know the importance of EGFR mutation. In a retrospective analysis in the EGFR mutated subgroup of patients, there was evidence of disease-free survival improvement of a hazard ratio of 0.61, but there was no overall survival benefit. Now, the CTONG1104 trial conducted in China, or known as the Adjuvant Trial, is a randomized open-label phase 3 trial, the use of adjuvant gefitinib versus chemotherapy in patients after surgery in stage 2 to 3A disease. Now, these patients had no prior systemic anti-cancer therapies, no prior radiation, randomized into 1-to-1 fashion. Again, 2 years of either gefitinib versus chemotherapy. And this was the cisplatin-vinorelbine combination. Primary endpoint was disease-free survival. Now, the median disease-free survival in this particular trial, gefitinib was 28.7 months versus chemotherapy of 18 months, and this was statistically significant. It did appear that the disease-free survival was better in the N2 subgroup, but this was actually not statistically significant in the N1 subgroup. There was no significant improvement in overall survival. However, there was improvements in terms of quality of life in patients who were on gefitinib versus chemotherapy. Now, the CTONG trial actually also gave us more questions, probably more questions than answers. And this is because a further look at this trial 2 years down the line at an updated conference, they actually looked at the disease-free survival at 3 and 5 years. And they both were commented to have significantly improved in patients who were given gefitinib compared to chemotherapy. This is the Kaplan-Meier curve presented with the 3-year DFS data. Again, you can see that the gefitinib arm performed better than the chemotherapy arm. But I think what's more important is what's hidden inside this graph. And this red line here is at 24 months since randomization. So this would be the time of the total treatment of 2 years. And what you can see, interestingly, is even in the patients in the gefitinib arm, about 40% of patients who were randomized to a TKI actually had disease progression prior to completing gefitinib. And there are certainly some questions to ponder when we look at these results. One is the survival curve seems to converge as time progresses. And the other thing is it really fair for us to be pitching EGFR TKIs against chemotherapy when we know that chemotherapy is at least a solid adjuvant treatment of which we really should consider benefiting from as well. Now, having said that, the CTONG1104 trial did give us some additional information, and that really has to do with the pattern of recurrence in patients who are treated with EGFR TKIs versus chemotherapy. And certainly, I think what's important to note is the fact that CNS metastasis is something that tends to be a big issue in patients with EGFR positive disease. And what we can see is it does appear that the gefitinib itself may not be all that protective for the CNS. Now, granted, it does appear that there seems to be more CNS metastasis in patients who are treated with gefitinib versus chemotherapy. But having said that, patients actually treated in the chemotherapy arm tend to have recurred earlier on in the extracranial disease. And maybe it's also possible to interpret this data really looking at the fact that patients who were treated with chemotherapy never got to a stage where they were able to develop CNS mets because they would have recurred elsewhere anyways. But looking at all the other data from all the clinical trials, that have used first-generation EGFR TKIs as an adjuvant treatment, it does appear that the protection of CNS is extremely important. And I think that is one of the main issues as to why our data with first-generation EGFR TKIs have not been all that successful. Now, I would like to spend some time talking about the ADAURA trial, and certainly this is the Osimertinib Adjuvant Trial, which is a third-generation EGFR TKI. The patients recruited were ones who have completely resected stage 1B, stage 2, or stage 3A non-small cell lung cancer, who were treated with or without adjuvant chemotherapy. These are the key inclusion criteria, which included, of course, patients who are adults, good performance status. They had to have either exon 19 deletion or L858R mutations in their tumors. And what's interesting and what's most important is including patients who have had prior chemotherapy or those who have not had prior chemotherapy. This trial was stratified based on the stage as well as the type of EGFR mutation and the ethnicity of the patients, of it being Asians versus non-Asians, randomized into a 1-to-1 fashion of osimertinib versus placebo, with a planned treatment duration of about 3 years. The treatment is continued upon until disease recurrence or when they've completed treatment or with one of the discontinuation criteria have been met. The primary endpoint of the ADAURA trial is for disease-free survival by investigator assessment. And the primary endpoint or the statistical analysis was geared towards looking at stage 2 and stage 3A patients. And this was designed for superiority and with under the assumed DFS hazard ratio of 0.7. Now, this is the baseline characteristics of the two treatment groups. Suffice to say that it is relatively well balanced between the two. If you look at the use of adjuvant chemotherapy, again, this was balanced. About 60% of patients in the osimertinib arm, as well as the placebo arm, had adjuvant chemotherapy before their recruitment into the trial. And I think this is always one of the biggest issues in terms of whether or not this is a possible confounder in terms of the results. Now, you would also be aware of the fact that the ADAURA trial was actually unblinded early, and an unplanned efficacy analysis took place that was requested by the Independent Data Monitoring Committee. And the primary endpoint was clinically and statistically significant, resulting in the IDMC recommending the unblinding of the results. And this was done in January 2020. Now, I think it is important to note that when we talk about this being unblinded, it was not a planned interim efficacy analysis, and the unblinding was requested because of the fact that there was evidence that there was clear superiority in the patients that were treated with osimertinib. Now, the unblinding was also carried out at the sponsor level instead of at the patient level, and I think this is sometimes quite often misinterpreted. So therefore, in actual fact, what that means is patients who are on the trial are not necessarily aware of the fact that they are or are not on osimertinib, but it's more of looking at the trial data set and knowing which patient is in which group. Of course, patients who actually had disease recurrence was subsequently unblinded, and they were and patients who were actually in the placebo arm were possibly given the choice of using osimertinib. Now, this is the primary results of the clinical trial itself. The primary endpoint, as I mentioned earlier, is a disease-free survival in patients with stage 2 or 3A. And what you can see is a clear superiority of osimertinib versus placebo. The disease-free survival was not reached in the osimertinib arm, but the hazard ratio was 0.17. Now, I think, as I mentioned earlier on, the CNS protection is extremely important. And I think it's quite clear that the use of osimertinib is protective against the CNS. And certainly at the 36-month time for randomization, so a treatment of 3 years, only 2% of patients within the osimertinib arm ever had evidence of CNS disease recurrence. The hazard ratio for this is 0.18. Now, the secondary endpoint is to look at the overall population. So this is essentially stage 1B as well as stage 2 and 3A. And what you can see is, again, a clear superiority of osimertinib versus placebo. The hazard ratio was 0.2. Again, the disease-free survival in the osimertinib arm was not reached at that time. And the improved efficacy of osimertinib versus placebo is seen across all the various subgroups, as you can see from this forest plot. This is actually, again, indicating the robustness of the efficacy of osimertinib in the overall population. If we look at the disease-free survivals by stage, what you can see is the hazard ratio in terms of the improvement based on the stage of the patients certainly is more significant in patients who had higher stage disease. But even in patients who had early stage disease, the overall hazard ratio was still quite significant at 0.39, and all of these met statistical parameters for significance as well. You can see the clear separation of the survival curve quite early on, and there does not seem to be any intertwining or converging of the survival curve that we saw in the CTONG clinical trial. Now, looking at the use of adjuvant chemotherapy in the patients who were recruited into this trial, I think it's suffice to say that, as you would have expected, the early stage patients, majority of the patients actually did not receive adjuvant platinum-based chemotherapy. And in the later stage patients up to stage 3A, the majority of the patients did receive adjuvant platinum-based chemotherapy. And the balance between the use of chemotherapy in the osimertinib versus the placebo arms were quite similar. This is actually the survival curve, so essentially looking at specifically patients who had adjuvant chemo and also patients who did not have adjuvant chemo, really just to demonstrate the fact that the use of osimertinib has been found to be robust in both settings. And again, a clear separation of the survival curve, be it in patients who have had adjuvant chemo or who have not had adjuvant chemo. And we can also see this across the different stages of the disease on presentation, echoing the robustness of the data. I think there does seem to be some crossover of the survival curves here in the stage 1B group, but I think it's also important to note that the number of events here have been relatively little, and we are also still waiting for some maturation of this data. This is just to demonstrate the fact that these events have been relatively small or low. And as you can see, at least in the time of presentation, the hazard ratio was not able to be calculated, and the upper boundary of the 95% confidence interval of the osimertinib group, again, was not reached at that time either. And also in patients who did not have adjuvant chemotherapy, we also did not have all the clear data. So we really need to wait for more maturity of this to really interpret this properly. But I think it's very important, and we always seem to get it mixed up, at least I hear from my colleagues and even from patients, there seems to be this misconception that the ADAURA trial have shown efficacy in patients who have had or have not had adjuvant chemo, so maybe osimertinib can replace chemotherapy. But I think it's important to know that this trial was never designed to assess the effect of adjuvant chemotherapy, but rather really is to assess the effect of osimertinib in patients who have either had or have not had adjuvant chemotherapy. And it was never designed for these two groups to be compared. Now, the pattern of recurrence, though, in patients who were treated with osimertinib is somewhat different from what we've seen from the CTONG trial, who were patients treated with gefitinib. And as you can see here, essentially, the most common sites of recurrence would actually be intrathoracic recurrences and not the CNS. Which echoes to the importance of CNS protection and the ability of osimertinib being able to achieve that. And if we look at this plot here, looking at the disease recurrence analysis, what you can see is in patients who were treated with Osimertinib, which is the ones in blue, the dark blue line showed evidence of CNS disease recurrence, and this was actually relatively low throughout the time since randomization. And most of the recurrences did occur outside of the CNS. Now, I don't think I need to go into too much detail in terms of the side effect profile of Osimertinib. I think we're all familiar with this drug. I don't think the side effect profile is any different for patients who are being treated in the adjuvant setting versus the metastatic setting. Just to note the fact that the grade 1 or 2 interstitial lung disease was reported in about 3% of patients, and certainly something that we should be aware of, but I think we are all quite well versed to look out for these and to treat these if these are really to occur. So I think at the end, Dr. Limaye has already showed you this, and really just to highlight the fact that Osimertinib has now been put into the NCCN guideline for essentially patients who are stage 1B, 2A, 2B, as well as 3A with EGFR mutations to be used in the adjuvant setting as one of the recommendations. So in conclusion, I just want to say that the ADAURA trial has shown a statistically significant and clinically meaningful improvement in disease-free survival in patients with stage 1B, 2, or 3A EGFR mutant non-small cell lung cancer. There does seem to be a consistent improvement in the disease-free survival, regardless of whether or not these patients have received prior adjuvant chemotherapy or not. Again, it's very important to note that this does not support the omission of chemotherapy in patients who are otherwise suitable or eligible. And I think it's important for us to convey this message to our physicians, as well as our patients who may see this as a possibility of omitting chemotherapy. I think one of the main reasons why Osimertinib is so successful is it has demonstrated a significant reduction in the risk of CNS disease versus placebo. And we're also quite well aware of the safety profile. And if we look at the ESMO magnitude of clinical benefit scale guideline, the adjuvant use of Osimertinib has been given an A score, which really shows the improvement of the efficacy of patients being treated with Osimertinib. So with this, I think I would like to end. I'd like to acknowledge my colleagues back in Hong Kong for holding down the fort while I'm giving this talk, although it is actually 10:40 at night. But in any case, I think it's a good time for me to take a pause, and certainly I'll be happy to answer any questions during the panel discussion a little later. So thank you very much for your attention.
Thank you, Professor Loong, and it was a pleasure listening to you. And as you mentioned, we had the privilege of having you over in our conference in Chennai, and very soon we look forward to having you once again in our city and also in our country. And it's always very insightful to listen from your experience also. And I think your emphatic presentation on what to read into and what not to read into from the ADAURA trial was very, very educative. And thank you so much for your excellent lecture. And once again, you're going to stay around for the panel discussion. And there is going to be a very interesting panel discussion. And the moderator is going to be Dr. Amit Rauthan. He's one of our dear friends. He's a very, very eminent practitioner from Bangalore. And he will be once again moderating a very stellar panel of many of the Indian faculty. Each one is very dynamic and well accomplished, all of them. And I'm so sorry, I'm having a call. Dr. Manish, Dr. Jyoti, Dr. Kaushal, Dr. Akash, and Professor Loong is going to be here. Dr. Deepak and Dr. Sewanti Limaye will be the panelists. And Dr. Amit, please take over. Thank you so much.
Thank you, Dr. Raja. So good evening, everyone. It was a wonderful 3 talks which we heard about all the data sets and how we test and what the real world experience has been. and then the data of osimertinib in the adjuvant setting. So I think we've had a great learning experience by these 3 talks. What my job will be is to quickly put it up in a panel of what we do in clinical practice. So let's just get started. So I welcome all the panelists. Let's start off with a case here. So quickly, this is a 67-year-old gentleman, non-smoker, presented with cough, and then the scan shows a mass in the left lung. There was some mediastinal node, and he was investigated appropriately. I won't go into the investigation of early stage lung cancer that takes. When we start with that in the panel discussion, then we never get to treatment. The whole debate ends up with medianoscopy, EBUS, biopsies, and staging workup. So I will leave that part. This patient was appropriately staged and managed, and he underwent surgery. Now, the biopsy report shows invasive adenocarcinoma, PT2N1 disease, and it was M0 in the PET scan. So we have a PT2N1 disease here for clinical management. So let's start off. Dr. Manish, shall I start off with you? How do you check for molecular markers in early stage lung cancer? What are the tests you are doing? Which testing platforms? And which samples are you using for testing?
Okay, yeah. So since it's an early stage lung cancer, and with the data we have now, that definitely I would like to have EGFR and on the tissue sample, and preferably by PCR, though NGS is also one of the options. And the reason is very clear, though we have data from Adjuvant Trial which says that we can add Osimertinib. But more than that, one more thing which I find interesting at times, that even when I choose to give patient adjuvant chemotherapy, the subset of patients which are EGFR positive, in those subset of patient, vinorelbine cisplatin combination apparently works better. So maybe that also helps me in deciding. So that thing in mind, I generally do EGFR upfront, in early breast cancer that way.
Oh, okay. So you kind of are using vinorelbine cisplatin for EGFR mutants.
Yeah, I mean, there's some not really, but yeah, there's a data. I mean, the subset, it says that in these patients do better. So what I had read and what I have realized.
Okay, right. Okay. So, but it is PCR testing is what you're talking of for EGFR mutants.
Yeah.
Right. Dr. Jyoti, what do you test and which tissue sample?
So in early stage, we know that right now we have targeted therapy as adjuvant treatment only for EGFR. But at our center, as part of our practice, we tend to prefer broad panel NGS. We have in-house facility to do lung panel 12 gene assay, but PCR is also all right to look for EGFR mutation. And we prefer to do it on post-surgery tissue. But sometimes the patients have already ordered on the pre-surgery tissue sample as well. So we get a mix of these two, but we would prefer to do it on post-surgery tissue.
Right. So that's the way the whole field is changing. We know because of the EGFR data, we test by PCR for EGFR, but so many centers have moved to NGS testing that eventually, even in the early stage, we just extrapolated and pushed the NGS there. And even all of us are doing, many patients are undergoing NGS testing, though sometimes those reports can be very tricky and what to do next can come up. Professor Loong, what do you do in Hong Kong for testing in early stage? Is it single gene, multiple genes, NGS?
Well, I think we have a very similar situation in India. I think each of the hospitals are doing it somewhat differently. I think EGFR is certainly something that all the hospitals are doing based on the fact that we have good adjuvant data now with Osimertinib. But I'm in the camp where I think it's good to have this knowledge early on, even if at that juncture, I don't have any sort of adjuvant treatment for. So right now, our standard would be essentially any pathology specimen that's sent to the pathologist labeled as lung cancer, they'll look and see whether or not there have been any biomarkers done for that particular patient earlier on. If they have not, they would still then do EGFR, ALK, ROS1, and Pdl1, even if it's a biopsy sample, if there is actually adequate tissue material. We have not embarked on a NGS for everybody yet in Hong Kong, but I think in the next 1 or 2 years, we're looking at maybe at least a small panel NGS for almost all our patients who are diagnosed with lung cancer.
Right. So at least looking for EGFR ALK cross and keeping that information for future. Yes,
Yeah,
I think yes, definitely. It makes sense to keep that, and because NGS is becoming cheaper and easily available, so even that's being used much more nowadays in early stage. I think it's all information for future. So now this patient ended up with a PCR test, and the molecular panel showed a EGFR mutation, exon 21. Dr. Kaushal, how would you manage this patient now in clinical practice? You have this stage and EGFR is positive.
I'd say it's a little bit tricky. There are two ways by which we can manage the patients. One is in clinical way is definitely we go ahead with the adjuvant chemotherapy with or without osimertinib, though the duration of the treatments and cost of the treatments is a matter at present. But still, I would like to go with the sequential chemotherapy as well as osimertinib.
Right. So it's chemo followed by osimertinib. So I think that's the perfect way, because as Dr. Loong mentioned, we should not omit chemotherapy for our patients. Those who are chemo indications, chemotherapy is the way forward. Dr. Akash, your thoughts on this? Okay.
Dr. Akash had an emergency, so he'll try to join you.
Right. I think Dr. Sewanti said she's leaving. Sewanti, if you're there, quick word before you leave. I'm sure you do NGS, and
yes.
so before you leave,
yes,
NGS.
So largely, if the patient comes in early stages, so I've now moved centers, but at Kokinaben we were doing EGFR ALK, EGFR for our patients early stage. And for those patients who are advanced, where gatekeepers are others and not me, the patient would always come with EGFR, ALK, ROS, and Pdl1. Where the patient came to me first, I would do because it's the tissue that you have to utilize to the max. And so I would do a broad panel at the start itself. But those patients who came already tested, many times they would come, but I would still want to do an extended lung panel on them if they had tissue. And most patients would agree, but some of them won't.
Right. So I kind of guessed that you would definitely say an NGS testing for those patients. I had a question, but if you're leaving, so I'll put...
You do NGS, right, Amit?
Yeah?
You also do NGS, right?
Yes, no doubt about it. Even we do an NGS in this group of patients. Again, keeping that information is what we think it's worth keeping that information for future.
So for Dr. Loong, I think he needs to know that, a lot of our testing is actually out of pocket. So as long as, if you have multiple genes that amount to 40,000 and you have a NGS test that amounts to 40,000, then, it's an equal kind of expenses for the patient. Sometimes you have to stretch a little, wherein you're still able to do the broad panel analysis for a contained price. And so that is the onus to get all the information.
Yeah, I think a lot of times, the strategy of testing is really dictated by the cost. Of course, the cost of NGS is coming down, and that would change as well. But I think it's interesting how the cost issue is different from different countries. So judging from what you're telling me, because your EGFR PCR test would cost a little anyways for the patient. And when you add single analyte tests to these patients, they might as well get an NGS. So it's quite interesting how costs actually can be interpreted differently in different jurisdictions.
So very recently, Amit, a patient came to me who had been given 8 different alterations separately to be done. And the molecular pathologist just looked at it and said, I would rather do a panel. And the patient came and told me the story that this is what was, the patient had gone to pay for each one of those genes recommended by someone. So interesting conversation.
Yeah. No, so that's what happens with this kind of test. So we had an early stage whom we operated and ended up doing an NGS, and it came out as ROS1 positive. And that was my last question for this early stage panel, but I'll put it now and finish it off because you're leaving, right? So what would you do? A ROS1 early stage post chemo?
So I'm not giving anything. I've presented, this, I presented at Impact And we have said we are not going to give anything in maintenance for ROS1 coverage or Ulc coverage.
Dr. Loong, you'd be tempted?
No, I mean, tempted, yes, but not tempted enough. No, I think the data is certainly strong for EGFR, but I think, for the other ones, we really don't have data. And, if we're subjecting patients to a long duration of treatment, the cost of it is just too much if we don't have solid data.
No, but my thought is when you get these rare ones like ROS and you're starting going to get RETs, you're not going to get the data. It's never going to come. So you're not going to have a trial about ROS in adjuvant. So somewhere down the line, you'll get tempted to extrapolate data because the data is never going to come. That's my thought.
True. But having said that, I would also think ROS may be tempting because ROS can be quite aggressive when they do come back. But I think somehow I have a feeling ALK is a different animal in itself. And I would be, we have very good and safe ALK inhibitors. Alectinib is very well tolerated. But, on the other hand, even with that, I'm not convinced that we should be using them in the adjuvant setting.
Right. Agreed. I think the data is clearly only for EGFR and we should stick to it. So let's move forward. Dr. Deepak, in this kind of a situation, let me tell you different case scenarios and let's kind of look at it. If you had a stage 1B, would you offer adjuvant osimertinib, or is it only for stage 2 and 3 as per where the maximum benefit was there? What are your thoughts on that?
Yeah, even for stage 1B, if you go back and see the 5-year survival rates, we see around 25% patients having the disease coming back. I would still continue. I would discuss this with my patient. I had one stage 1B. We discussed the benefits and the side effects and the longevity for which they have to go on osimertinib, and they were unwilling for that medication. But I would discuss that with each and every patient. I would definitely recommend it for my patient. I leave it to the patient, but I would definitely recommend that for the patient.
Right. So 1B also, you are convinced to discuss it about your patient. Yes, the data is clearly there, but we do hear different interpretations to that. Dr. Loong, 1B for you is a sure shot?
I think 1B, I think the data is there. I think it depends on how you look at it. Are you looking at it from the patient, single patient in front of you point of view, or are you looking from like a health economics point of view as to whether or not these, you're going to be spending, that amount of money on that particular patient. For us, for example, even osimertinib in the adjuvant setting, actually patients have to pay out of pocket. So in that situation, it makes it easier. And if the data for 1B is there and the patient is willing to pay, then I'm happy to prescribe. But I could understand why in some jurisdictions, if it's really about reimbursement and they look at the risk of stage 2 and 3A being higher and only covering those, I could understand that as well.
Right. Yes, Dr. Manish.
Yeah, I would like to mention one thing here. 2 of my patients of stage 1B, they are on osimertinib, and of course, one of them has started when I was in Army earlier in our hospital, and their patient did not have to pay because it was obviously government sponsored. But before I started osimertinib, I told them about the trial in great detail. I told them that this is what we have a benefit in hand, and there are certain things which we don't know, which are uncertain, and you have to take this treatment for 3 years, and you may have to face certain side effects. So after explaining, patient was okay, so I started. But yeah, there are some area which we must discuss with the patient and tell them before we put them on osimertinib.
Yeah, no, but when you talk to them, we talk more about the PFS, and when you see these kind of PFS curves, I don't think it's too difficult to convince a patient. They look at it, they understand.
Yeah, I completely agree with you, Dr. Amit, that it's very compelling, very encouraging. But we all know the issues with Adjuvant Trial, that where we have to we have certain questions which remain unanswered. So I feel duty bound to tell the patient if he has to be put on adjuvant therapy for 3 years, and certain things have to be explained. So I do that. I'm not just saying that everybody has to do it, just that that's a disclosure.
No, absolutely. That's my next question. So, Dr. Jyoti, do you think Adjuvant is practice changing for all your patients, or do you think you're going to wait for the overall survivors? Because eventually everyone says the same thing, that we want the OS data. And eventually we are assuming the OS data is going to be very good because the way the curves are and the way the CNS penetration is, but we still don't know that.
See, the data is very impressive. The hazard ratios are really compelling, 0.17, 0.20. This kind of data can't be ignored. So according to me, the data is impressive. And it is practice changing. The data definitely needs to be shared with the patients if finances are of no concern. If they can afford to take it for 3 years, yes, it's worth offering them this. And obviously, we'll be also sharing with them that we don't have OS advantage demonstrated as yet. So we let them choose, but it's worth discussing with all the patients, stage 1B, 2, and 3A. So I would do that in my practice.
Right, right. So I think all of us are doing this in practice now. We're talking to all our patients, explaining about the benefit and explaining about the lack of OS as of now. But yes, all of us think that with this kind of PFS, if you don't get OS, it's be very, very surprising. But again, let's see how the data pans out. Dr. Deepak, just an extension to not specific to ADAURA. It's just that if you had a 3B whom you went and got CTRT, what do you do after that? Do you extrapolate ADAURA there? Or are you in the Pacific group? This is another 2 groups we hear whenever we talk to people. Are you in the Pacific group or the extension of the ADAURA group, I would say?
As per the trial, I go with the Pacific data, but deep down if the patient is really pushing hard to go on immunotherapy for the financial constraints, I really don't push these patients on either of these drugs. I wait for them to have the disease coming back, and then I put them on either Osimertinib. We eventually have to wait for the LAURA data coming up. We have to see what the LAURA really tells us about this specific group. But in these group of patients, even the Pacific subset really you go back to multiple analysis, even single institution data says that EGFR positive patients really do not derive great benefit from Durva. And that's been my practice too. I've got my hands in a few of these patients. So I'm a little reluctant in introducing Durva, not very aggressive in adding OC in these group of patients.
You're not for Pacific, but you're not extending ADAURA. Okay, so you're sitting somewhere in both ways. Okay, Dr. Kaushal, my question to you, same way. Do you sit and giving? This becomes a practice challenge for us. I would ask you, what do you do, Dr. Kaushal, in this group?
The patient who has taken the radiation therapy, chemo radiation therapy,
correct.
I will go with the Pacific.
Okay, so you are the Pacific. Okay.
Yeah, because we do not have any data like that after the radiation therapy with Osimertinib or any EGFR TKI. So we can definitely go with the data.
So yeah, no, I absolutely agree. That Pacific is the data. Dr. Jyoti, this side.
So currently, as per current guidelines, Pacific is the way to go. But also remember that the IO limitation in EGFR mutated patients. And it's also important to remember the gap between Osimertinib and IO. Just in case these patients recur too fast after completing the maintenance durvalumab, it's very important to keep that at least 3 months gap between Osimertinib and durvalumab. So that's another thing to be kept in mind.
Right, you're right about that. We should always remember
to pitch in here, I had the same issue. The patient progressed while on Durva, had brain metastasis, had to be started on OC, had really bad pneumonitis, and we were stuck at that point of time. So yeah, I would have your inputs, Dr. Loong and Dr. Amit, both of your inputs. If you have an EGFR positive patient post chemo radiation, how would you deal with these group of patients?
So Dr. Loong, what do you do?
No, this is a really good discussion. I mean, I've been thinking. I think I agree that Pacific is where the data is, but given all the caveats of EGFR positive disease and the lack of response with IO, and to be honest, anybody with stage 3B, they will recur. There's a very good chance that they will recur even with chemo RT, despite the fact that it's still considered curative. They will within a short period, within a period of time. I would actually be tempted to give Osimertinib. They will not be reimbursed. It's not an on indication, but if it's something that they can afford, certainly in terms of the side effect profile, I'm quite happy with. And I think at least it depends on how you look at it. I mean, if you feel that these patients would likely recur later on anyways, it's sort of a preemptive use of a palliative treatment, which is well tolerated, and maybe you'll keep them disease-free for at least 3 years, which probably is better than what you would get from durvalumab anyways, in terms of the adjuvant treatment.
Right. I can tell you what I think. This is one place where I clearly would say, if we say the biology of EGFR is for 1B, 2A, 2B, 3A, And then we say stage 4 biology of EGFR is the same. Why should we leave the 3 Bs? So my thought is, I'm not for Pacific in this group. This is the one group where I would go for osimertinib, though there's no data, and I would extrapolate data, which is wrong to do, I know, but I'm not for Pacific in this group. But again, this is a very healthy discussion we should have, and we should tell all our patients what the whole pros and cons are and what the data is when we do it in our practice. Okay, so I think we will just one quick question to finish off. Doctor, a quick thought? You've seen the Checkmate 816 data. You've seen the neoadjuvant data for early stage. Will that have some role to play in this group of patients anywhere? Where would you place the neoadjuvant data sets? Dr. Manish, your thoughts?
I would say it's a bit early. I would like to wait for some time and see and before starting. So not yet.
Okay, so no role at present. Dr. Loong, where would you place this 816 data coming in now for practice?
I don't know. I think, in all honesty, again, for the EGFR population, of course, they were included in the trial, but small numbers. And, I still think EGFR is a different biology in itself. And I mean, I would then actually think about, the neoadjuvant use of EGFR TKIs more than an IO, which even if it's, ipi-nivo of both PD-1 as well as CTLA-4, there really is no reason why the response rate, at least in the neoadjuvant setting, would be any better than osimertinib, right? So, of course, if you're looking for some sort of immune control for a longer duration, yes. But I think in a neoadjuvant setting, what you really want to do is be able to shrink it so that you could then go on with your definitive treatment. And there really is no reason why osimertinib would not fare at least equal, if not better than IO. So I think the issue is we haven't had good trials designed properly. We didn't have a good EGFR TKI, but now we have a good one, and we need to wait for the readout of the results.
Right. Excellent. I think all valid points, because we just don't have the data, and I think there's that neoadjuvant osimertinib trial, and that's probably going to help in answering some more questions. So I think quickly we finish this panel, and just a quick panel on the metastatic setting. Just a couple of questions. Kashish, you'll have to tell me if the time is up. So let's just quickly discuss this. Stage 4 EGFR mutant L858R stage 4 patient, adeno-CA. What is your first line of therapy in this group of patients? Dr. Akash, you've joined. I think I'll put this question to you.
Sir, we offer these patients osimertinib if there are no logistical constraints. In our practice, if they have logistical constraints, we give these patients a combo of gefitinib with chemotherapy.
Okay, right. So that's the way it's going. And does anyone differ in the type of mutation, 19 and 21, to choose osimertinib or anything else? Dr. Akash?
So I think, sir, I do not. But I think a subgroup analysis may be insufficient to drive our choices.
Right. Dr. Jyoti, what do you do for this group of patients, L858R? How would you treat this?
Osimertinib is my drug of choice for first-line treatment in these patients. And most of my patients are able to say yes to it. But if they can't afford osimertinib, then I would concur with Dr. Akash. I would offer them gefitinib with chemotherapy.
Right. So we do use gefitinib plus chemo a lot in India, and we've seen very good results. And that's something definitely a good option for our patients, especially those who can't afford osimertinib. Dr. Loong, in Hong Kong, everyone is on osimertinib for this group of patients?
No. In actual fact, I mean, osimertinib, again, we have the label for it. It's approved, but it's not reimbursed. So it's reimbursed. Hong Kong has a really interesting way of reimbursement. What you have to do is go through a financial assessment. If you meet the criteria, then you could get it for free. But if you don't meet the criteria, then you'll have to pay out of pocket. So in Hong Kong, you should either be very rich or very poor. The people in the middle never get any good medical care. But that being aside, so osimertinib would be my first choice if I can use. If not, then it would be either a first gen or a second gen EGFR TKI. These in itself are completely reimbursed. I'm certainly aware of the data of gefitinib plus chemotherapy coming from India mainly. We haven't actually had much experience of using TKI plus chemo, so I'll be very interested to learn more from the panel in terms of the improvement in efficacy in this group.
Right. Dr. Manish, you'd like to comment your experience with this?
Well, I would definitely go with Dr. Jyoti and what Dr. Akash said, that first choice would be osimertinib in case the patient can afford it. Otherwise, gefitinib plus chemotherapy. We have the TMH data and we have our own experience as well using this combination. It works fairly well. So either of these two, depending upon the patient's condition.
I think this is one thing you will hear in every Indian panel. In India, all of us use a lot of gefitinib with chemo if our patients can't afford osimertinib, and the efficacy is good, and they tolerate it very well. It's very well tolerated. There's really no major issues which all of us face. A question about ramucirumab, Dr. Deepak, do you use this combination? Especially we've seen the 21 versus 19 data. We said Ram gives us equally good PFSs in both. Do you use this in any patients?
Yeah, I think you were just reading my mind, sir. I was just trying to interrupt on the same point. I use Rami-Erlo in all my patients who are affordable without brain metastasis. In patients who are not who are affordable but with brain metastasis, I go with OC. And patients who are not affordable, I give PEM plus gefitinib, pemetrexed, carboplatin, and gefitinib. This is how I treat my patients. And what I've seen, at least in my practice and with the retrospective analysis which we've seen over the last 3 years, is combinations fare very well irrespective of the kind of mutations. If you're using single agent TKIs, I think that's where 19 and 21 mutations really pitch in. That's my experience so far. Yeah, I use Rami-Erlo in patients who are affordable without brain metastasis.
Okay. So that's the group where it's really used and shown very promising data. We have very limited experience. At least I have very limited experience about this, but we keep hearing from different centers about people using it, and so it'll be very interesting to see. And I think all of us are waiting for the Relay OS data to. If that comes up, then it becomes very convincing. Okay, so we are running short of time. Quickly, a couple of more questions. If you had brain mets, SRT is the way. How many mets are you comfortable with doing SRT and continuing osimertinib? What do you do in practice, Dr. Manish?
So ideally 3 to 4, but also depends upon how much my radiologist is, radiation oncologist is comfortable with, and then 3 to 4 is an average, yes. And then
Dr. Loong, is it like very aggressive SRT centers in your place?
No, I think for us, I think typically it's about 3 would be the magic number. Again, it also depends on the radiation oncologist, how willing they are. But for us, we would declare anybody with more than 3 brain mets, then it would probably be osimertinib failure, and then radiation, and then move on to something else.
Right. So I think all of us follow that, though we hear from some very aggressive SRT centers doing much more, and we haven't done that, so that was very kind of reassuring that that's what all of us follow, right? So let me put up one of my last few patients which we saw in clinic. So this patient, we did an NGS, and it turned out there's an EGFR mutation. It's del19. There's a P53, and there's an RB loss in the NGS. So we have the three mutations which we are seeing there. Would that make you think differently in this group of patients? What I'm trying to talk about is, if you get these multiple mutations, do you think differently in practice? Dr. Kaushal, what would you do for such a patient? You have an EGFR del19. There was also an RB and a P53.
Yeah, to a certain extent, T53 positivity is per se one of the, we can say, the poor prognostic or sometimes resistant to the treatment option. So if the possible, then we should go ahead with the best possible treatment options. That would be the osimertinib. We can have, just we mentioned earlier, we can go ahead with the ramucirumab plus erlotinib also. But still, I would like to go with the best possible option in this population.
Right, that's what comes to mind. But we keep thinking, is this enough? Dr. Manish, what would you do?
Well, I agree. Osimertinib would be the choice, but I may consider afatinib because del19 positivity, and when maybe some OS benefit, and otherwise, if not osimertinib, then afatinib may be my choice.
Okay, we've stopped using afatinib for 1921s now.
Yeah.
We reserve it all for uncommon mutations, much
Yes,
more.
I agree.
Because Osimertinib is a much better drug and an
Yeah,
easier tolerated
yes.
drug also. Dr. Jyoti, would you think differently or would you look at the same way?
Currently would offer the same treatment, osimertinib being the preferred treatment suggested to the patient. But as another panelist already suggested, P53 mutation may be a marker for chemoresistance and radioresistance. So that's my current knowledge. But how they interact with each other in combo with RB and P53 along with EGFR, that I'm not very sure of.
Right. So Dr. Loong, this is the last question to you, and then I think we should wind up the panel. We're running short of time. Dr. Loong, what would you do for this group of patients?
Yeah, I think right now it's pretty much a prognostic marker without much influence in terms of prediction of treatment. So I would still treat them very similarly. I think the only thing would be watch them more closely, make sure we get the interval scans on time, also image the brain as well, and move on to chemotherapy if there's evidence of progression.
Right. So even if we have multiple mutations, as of now, the information still is the same. We really don't have anything to say that that would be a better treatment. So I think that's what most of us would do. So with this, I would like to conclude. I think thank you everyone. It's been a wonderful discussion. I've put up all sorts of questions which we face in clinics, and I've had some wonderful answers. It's just been a learning experience for me. Thank you very much, Professor Loong, and thank you all the faculty members for this. Thank you very much.
Thank you so much, sir. Yeah. So please go ahead.
No, I was just trying to conclude and hand it to you. So thank you for that excellent learning experience. So Kashish, over to you.
Thank you so much, sir. Thank you, Amit, sir. Thank you, Herbert, sir. And thank you to all the panelists. And also thank you to Raja, sir, and Sewanti, ma'am. And with that, we come to an end to the session. And I wish everyone a happy weekend. Thank you, everyone.
Thank you. Bye.